Thanks everyone for joining. I'm Bobby. I'm the co-founder and CEO of Elion, and thrilled today to be hosting our conversation on voice AI and how it's being evaluated, adopted, and scaled in practice. So we're constantly at Elion talking to health systems and large provider organizations about where they're focused from a technology perspective, and voice AI, I'd say, has probably been one of the top three, if not the top topic that's been coming up in our conversations. And the reasons for it, I think, are fairly obvious. There's benefits around better patient experience, lower costs, better results across areas like appointment scheduling. But there's always a lot of questions that come up about how it works in practice. How easy is it to set up? How do you ensure that it's performing well over time? How are patients actually responding to voice AI? And then are you actually seeing real ROI and impact? So we are very lucky today. We've got three practitioners from large provider organizations who are all in various stages of implementing and scaling voice AI solutions across both different settings and different use cases. And so we're going to kick off first just by having each of them introduce themselves. And so, Matt, I am going to start with you.
Great, thanks. My name is Matt Cantonis. I'm the Chief Operating Officer of the University of South Florida Tampa General Physicians Medical Practice. We are a large academic medical group servicing the Tampa, St. Pete, Clearwater metro service area and broader along the west coast of Florida. I also have responsibility for our central scheduling call center operations, and we have recently partnered with Hyro to provide a expanding digital host for us. We started about 6 months ago.
Great. DJ?
Hey, happy Monday, everyone. My name is DJ McKerr. I'm the Vice President of Strategic Operations and Innovation for Gastro Health. I spend about half my time on M&A and integration, the other half on enterprise programs, inclusive of all AI supported initiatives across our 600 providers, 200 locations in 7 states that we service today. We are the largest GI independent practice in the country and with large presence across the Midwest, East Coast, and Southeast.
Great. And Orla?
Thank you, Bobby. Hi, everyone. I'm Orla Seidel, Director of Digital Marketing for Atlantic Health, a leading health system in New Jersey with 8 hospitals, 550 sites of care, and 25,000 employees. I am responsible for CRM, performance marketing, paid media, and marketing analytics. At Atlantic Health, we've been using AI for clinical and operational use cases for some time, but this is our first year using voice AI for interactive patient communications. We partnered with Artera to launch AI virtual assistants for procedure prep in February, and we are partnering with Hyro to launch AI-assisted call routing next month.
Great.
I'm happy to be here.
Thanks, everyone. And so just before we dive into the conversation, wanted to mention one thing quickly on our end. So we are actually hosting an executive summit in mid-June in Austin on topics that are very relevant to today's conversation. So how AI is impacting patient growth, access, and engagement. And the whole focus is really around how do we help leaders at health systems and large provider organizations accelerate their understanding and decision-making across these categories. And so essentially it brings together leaders from about 15 to 20 health systems alongside a vetted set of vendors in each of these categories to just learn what are they doing, how do they see their solution and how it compares to others, and then give the leaders in attendance a chance to learn from each other and their own experiences. And so if you're making decisions in these categories this year and this is relevant to you, feel free to reach out. You can check out the link on this slide or email my colleague Jeremy at jeremy@elion.health. And yeah, so with that, let's dive into the actual conversation. 1 second. So yeah, so DJ, we're going to start with you. So you're actually in the thick of evaluating several different potential solutions, and you're going through a pretty rigorous process, one of the more rigorous ones I'll say we've seen. I wanted to see if you could walk us through how you've set it up and really what you've learned from going through this process.
Yeah, absolutely. So we're very much in a pilot bake-off status at this moment. We're considering 3 vendors, Artera, Clarion, and then our EHR vendor, eClinicalWorks product, as well as a potential solution. But we started with many more in this process, to your point, Bobby, that it seemed like there was almost an evergreen pipeline of AI companies coming to us on almost a weekly basis, whether it was through LinkedIn outreach, from a physician referral, something we've observed maybe with one of our health system partners utilizing as well. And what we really realized is that we had to have a structured process to really look through this. And we didn't want to make it too rigorous where it slowed us down, but we wanted to be thoughtful enough with the process to really ensure that if we're spending time and energy to stand up this pilot or this bake-off with these vendors, that we can ensure when we're on the other side of it, we're going to have the outcome that we wanted. So we had over 15 vendors participate in what I would describe as kind of an RFI process, focused on not just the capabilities that they have today, but also what are things that they will deploy in the future, whether it be this year, next year, and beyond. Some high-level economics to make sure we're kind of aligned on those, and really making sure it cleared some of our key hurdles, whether it was security requirements, having experience with eClinicalWorks in our instance, or having experience in the GI space, which really helped down select a number of vendors that did not have that for us, and really focus us on a core group that had capabilities that we felt met our current needs. And then the evaluation became really focused on, because we don't want to have 10, 15, 20 different point solutions, where do we start to see the vendors that we think will grow with us, that will bring more solutions to market and really continue to be leading edge beyond just voice AI for contact centers.
Got it. I'll circle back to your actual pilot experience in just a second, but Orla, I want to come to you. You guys picked procedure prep for colonoscopies as your starting use case, which I think is a pretty specific, interesting choice. And so I'm just curious, how did you guys land on that?
Yeah. For us at Atlantic Health, it's so important that we're not using AI just to make headlines, right? Everybody's talking about it. We do not want to come up with some sort of flashy AI solution to a problem we don't have. So this didn't start as an AI initiative. It started really with a business need. And for us, colonoscopies have a higher cancellation or no-show rate than any other same-day surgery procedure. And why? Because the preparation for a colonoscopy is lengthy, it's complex, it's confusing, and it is very unpleasant, right? There's all types of steps that a patient needs to take in the days leading up to their procedure, and it can be very overwhelming. And if a patient doesn't take those steps at the right time, the day of their procedure will come around and we can't perform the procedure on them. And so those late cancellations are like empty seats on an airplane. So we really wanted to come up with a solution to help answer patients' questions, help them feel more prepared, and increase our completion percentages for those colonoscopies. So we had these goals: reduce operational burden of our teammates, placing those phone calls and sort of begging patients to please be prepared. Do you have any questions? Increasing those completion percentages, and then really helping patients feel more informed and have the opportunity to ask questions. So for us, technology was the solution. We wanted to use some sort of tool that would give us the automation and the personalization that we were looking for. And we had an existing partnership with Artera, a longstanding partnership with an integration into our EMR. So we wanted to sort of experiment with this new technology to be able to do those things.
Great. And Matt, you guys moved really quickly here. You went from your first serious conversation, with the partner you're working with, to live in roughly 3 months with no pilot. Can you talk a little bit about how you were able to move so quickly there?
Yeah. I mean, I really liked what Orla said. We focused on a business need here and had spent a significant amount of time, really almost the entirety of the 18 months leading up to the decision to go live with a digital host on our call center platform, doing extensive amount of scheduling, cleanup work, everything around the back end of our Epic modules with decision tree maintenance, our knowledge management platform, deploying the Cheers CRM module, and dramatically simplifying the visit type variability and standardizing our template design. And what this actually ended up giving us the ability to do was layer technology into a process that had been recently cleaned up and had been simplified from a rule set standpoint. So that allowed us to go really fast and relatively deep in a short period of time. Very simply stood up call routing and started to layer complexity after that.
Yeah, I think that's really interesting. Just anecdotally through a lot of our conversations with health systems, this concept of automation readiness has come up again and again and again. So, in order to have successful implementations, it turns out terribly if you layer AI on top of a set of bad, unorganized processes, but it can be super efficient and effective if you've got, your ducks in a row going in. So I think really resonates a lot with what we've been hearing from other folks as well.
Yeah.
Cool. Well, DJ, I want to come back to you on the pilot experience. So I know, intentionally picked some pilot sites that I think you mentioned said would be sufficiently hairy to roll out with. So can you talk a little bit about what this actually means and the approach that you took and how you're thinking about success there?
Yeah, absolutely. As we kind of think about this, it's spending, I call it sometimes going slow to go fast, spending a little bit more time up at the front end of the process, whether it's the RFI or with our evaluation period here, to make sure we complete something that's really representatively complex of the organization. It could be organizations that struggle with call abandonment rates today, that maybe have staff turnover issues, that maybe have multiple locations that they're practicing out of, or multiple groups working at a single location, right? These aren't as maybe singular, simple FAQ type questions. And one, we wanted to get the kind of immediate benefit for the groups that really needed help, but also really use it as a litmus test to stress test and train the model of something that will hopefully be simpler at other locations as we deploy it in the future as well throughout it all. Something else that we kind of thought in this lens too of, beyond just the call abandonment rates, you have your kind of traditional contact center metrics on the cost side, but also what are some of the kind of revenue capture opportunities for us, whether it's reducing no-show rate like Orla talked about as it relates to colonoscopies, whether it is getting more new patients into our care centers because we're able to schedule and reschedule more aptly. And then, ultimately, what is the patient satisfaction at the end of this? How are they engaging with AI? What are their thoughts as a part of it, and being able to audit some of those different ones as well? A lot of times when we do approach audits, we think about, or excuse me, pilots, we think about it in terms of, what is a lower performing site and what's a high performing site. And that kind of gives us two bounds to, evaluate it between. It sees the growth we get from a lower performing site on whatever metric it may be. And then for a site that already believes they're high performing, it shows us how much more, we can do better as a part of that too. So we really feel like we're collecting some robust data right now on our pilot, and we're just a month into it at the moment, that will really create a compelling case for us to deploy across our entire enterprise.
And this is putting you on the spot a little bit because I know you're pretty early in the pilot phase, but any initial kind of learnings or observations or anything that you would call out for folks who are maybe a step behind you and starting to think about a pilot?
One thing that I have appreciated so far with all of our vendors that we've been partnering with is just the responsiveness to it. So I think there's this fear a little bit of what happens if a patient has a bad experience or a call is mishandled, or, you book it into the wrong appointment type. What we found really fast is that we've been able to push through that and then, retrain the model again to self-correct moving forward for that. So I would say, it's put a lot of people at ease a little bit that, we're not making mistakes more quickly as a part of it, but rather get to an answer at kind of the quickest path possible, and are able to incorporate that moving forward for us as we continue to train and deploy the tool.
Matt, again, I know you guys went live really quickly. So can you talk a little bit about what those first few weeks actually looked like for you?
Yeah, I mean, it's nice to be on here with DJ and Orla. Like our stories are so similar, and I think that just resonates with, hopefully, with the audience is can anticipate or probably going through at the same time. I think we're all trying to figure this out. But yeah, we went live really, really fast. And I think the biggest challenge with as I've reflected on it in prep for this, is that we went from sort of a traditional IT support structure where, like, if Epic's broken, you put a ticket in and IT fixes it, right? Like the operator recognizes they can't, do whatever they need to do, and they put a ticket in and, like, it works. this isn't really that same relationship with IT. This is a relationship where the operator is actually managing a member of a digital workforce. And so what is happening, the AI works perfectly, like every time. It does exactly what you tell it to do. So if it's not doing the right thing, it's because you need to manage it differently. And that's really not something IT is going to figure out. In our instance, we had like instantaneously 20% more calls that were going to our central clinical messaging team. And at first, the clinical messaging team was like, the tech is broken. And when we went and investigated the tech and listened to the calls, that's not what was happening. What we figured out was happening before was patients were picking whatever, number on the IVR they were used to. They were getting to the central call center team, and that call center team was managing their issue without routing it to the central clinical messaging team, which really was inappropriate. We want scheduling agents making appointments. We want clinical messaging agents doing their book of work, but it did result in a real problem. We all of a sudden were way understaffed for the demand that was placed on that team, and we had to adapt operationally. This wasn't a tech fix. This was an operational problem that the leadership team had to change.
Yeah, that's super interesting. That actually implementing it highlighted a gap in your current processes.
And that's not AI specific, right? That
Yeah.
any tech has a great way of highlighting broken processes.
Yeah. Orla, you, I know, have been very deliberate about ensuring that the agent you're working with is only drawing from your own knowledge base. And so I was curious if you could talk a little bit about what that, like, why you guys have been so clear, careful about that, and what it's actually looked like to put that together.
Yeah, thank you, Bobby. Yeah, we wanted a lot of control over what these agents were going to be saying because the agents are calling patients proactively to walk them through these steps and answer any questions they might have. So we wanted to make sure that they were drawing only on Atlantic Health approved intelligence and knowledge and our guidance because we hold ourselves to a really high standard. And I think when a lot of people think about AI agents, if you ask ChatGPT, can I take an Uber home for my colonoscopy? It will say yes. But Atlantic Health says, no, we don't want you to do that for your own safety. So we wanted to make sure we had control, that these agents weren't going to be pulling information from the web or from any other sources aside from what we would train our own staff members to say. So we trained the model with this 14-page prep pack and then over 80 FAQs. Every question that we heard from our callers, what do people ask about colonoscopy? We documented, think about operational documentation, documenting those answers, getting those answers really officially approved by clinical and operational leadership, and then training the agent on those answers. And it's been just so fascinating because we found that the agents are now able to more consistently, reliably, and thoroughly answer all of these questions in a way that probably a live human wouldn't be able to draw on all of that information, right? No person could remember all of those clinically approved answers right off the cuff when they're calling patients. And then another thing it enabled us to do is speak in our patient's preferred language, which is really important with our diverse patient population in New Jersey. So it really added more capabilities in what live humans can deliver for engaging these patients in these questions. And we found that while that scripting and that operational consistency and how you would answer all these questions was so important for us to document first before we train the agent, that was sort of the straightforward part of it. The harder part was understanding all of the ways that a patient could ask questions to the agent, right? Are they saying blood thinners or anticoagulants? And then does the agent understand the intent of what the patient is asking? So the LLM part of the agents is really where the value came from. And that's what makes it different than IVR, right? Anyone can script one-to-one answers to questions, but the LLM component really understands tone. And if the patient is stressed, it will reassure them that this is a great step that they're taking in their health journey. It kind of demonstrates that empathy. If the patient's joking, it understands that the patient is joking. If they're stressed, frustrated, it picks up on all of that. So it's able to have all of that knowledge, but then have the human component, which is really demonstrative of the type of care that we try to deliver at Atlantic Health. So that was, we just wanted to feel like we owned it and that it was representing the way that we would want to talk to our patients if we were talking to them live.
Yeah, makes total sense. And then just a quick follow-up, because I know you mentioned maybe one of the unexpected technical challenges that you guys encountered with going live. Can you talk a little bit about what that looked like?
Yeah, for us, the biggest challenge was latency. When we started in development, it's just like talking to ChatGPT. We've all experienced this where you're saying something to ChatGPT, there's a little bit of a lag, and then you say it again. And then ChatGPT is responding to the first thing you said. That kept happening because we built our own knowledge base. So the model was drawing on our own knowledge to make sure it had the Atlantic Health approved workflow, but we had to experiment with different models to get that type of speed that we wanted. So we had to try a few different LLM models before we got the right kind of balance between the speed and ability to more lifelike conversation with those very deliberate Atlantic Health specific scripted workflows. So that part was the hardest. A patient would say hello and there'd be a lag. And so of course they're going to say hello again, or they're going to hang up before the agent even has had a chance to talk. So iterating through that, I did not expect that technically, but it was a great learning experience for us.
Yeah, yeah, makes sense. I want to shift gears to another topic that I think comes up quite a bit. I mean, really across any sort of AI implementation, which is change management, particularly with teams, frontline operational teams. And Matt, I know you guys took a really interesting approach to this
Yeah.
with your team. So I wonder if you could just talk a little bit about kind of what you did, why you took that approach, and how the teams responded.
Yeah, the timing of our implementation was interesting. In the 6 weeks prior to us going live with this capability, there were over 100,000 layoffs in Fortune 500 companies that cited AI. So, we were thinking ourselves, these people, our call center agents are going to really feel threatened by this. And what can we do? And I think there's really only one choice in situations like that, and it's be tremendously, like, unapologetically transparent, which meant tell them exactly what we were planning to do. And the implementation of our first model digital host had no possible way it was going to replace a human. In fact, in many ways, it was easy for us to communicate to the teams how this was going to make things easy. And in the first couple of weeks, we had it up doing cancellations and reschedules on a one-to-one match. The simplest, easiest thing that our agents do today. And when you talk to them out there, it's just been a tremendous improvement to their sort of job satisfaction. They get to handle the more complex issues. They talk to the patients who have a greater need and have larger concerns. But we also needed to make it feel real. Like, this wasn't something we were just trying. This was something we were doing. We weren't putting a toe in the water. We didn't pilot, as you said. We were all in. So we had AI generate us a humanoid looking thing. We turned it into a cardboard cutout, gave it a badge, gave it a cube. We threw like a gotcha party like families do when they adopt a child. We dress her up for the holidays. We've taken her to various leadership meetings. At one point, we even used AI to bring her to life. And it's actually wild, but we have this video of our agent taking a phone call, and the audio is a live patient call. And she's sitting there behind her computer screen looking no different than I am right now, speaking to the audio. And it is, we have made her feel like a teammate. I'm 20 feet from her cube right now. And she was a little slow in taking her Easter ears off, but I'm sure she's getting ready for Memorial Day soon.
That's pretty incredible. And obviously the team responded well to
They
that approach.
They wrote her welcome notes. They are very supportive of making her better. I think they recognize that AI will not replace them unless they sort of resist using the AI to help them be better.
And has that goodwill carried forward? Because, that it makes sense to me that in the early days when they're taking, maybe the stuff that's most rote off their plate, people are more comfortable with that, even grateful for that. But as or she becomes more capable, takes, higher or more challenging workflows, have you seen that perspective change over time?
We're studying this right now. Obviously, we have a tight relationship with the University of South Florida, and a professor from the Muma College of Business and I are actually studying the design principles and the implementation of this agent to help us understand how we best roll this out in a complementary fashion. Um, you know, Scheduling at a quaternary tertiary academic medical center is always going to have a degree of nuance and patient sensitivity that I think at least in the next 2 to 3 years, AI isn't going to even scratch. Um, However, as anybody who runs a call center knows, there's 30% turnover a year. And you don't have solid straight line demand. I get 80% of my calls in 3 hours between 11 a.m. and 2 p.m. And I don't have the ability to scale agents like that. AI is infinitely scalable in that way. So I think it gives us an enhanced capability, but it's unlikely to be something that completely eliminates call center agents. And our team understands that. They've been volunteering to get trained up and cross-trained on different skills. And they're looking forward to helping us deploy an enhanced capability across our entire platform.
Super interesting. DJ, I know, for a lot of folks, AI talking to patients feels riskier than a lot of other, AI use cases, especially some of the early ones that were rolled out. And so, I'm curious for you guys, again, as you're going through this kind of piloting process, how have you thought about guardrails there and getting comfortable with that?
Yeah, definitely feels a little bit more complex and heavy than, just calling to pay a bill over the phone or something along those lines. And so we've thought about it in a couple of ways. I think people really focus sometimes on the exceptions, and, it's those exceptions where we spend a lot of the time, or, the 0.1% of cases or calls that come in. Now, we definitely do want to be thoughtful and intentional with that. But for us, it was starting with really simple use cases. So we know that scheduling and rescheduling calls make up about 70% of our volume today. Medication refills another 15%, and then the remaining 15% is FAQs or anything else that come in that might be outside of that. So we've really felt that by starting with scheduling and medication refills, that was really going to drive a ton of the value, and those are much more straightforward use cases for us. Now, you never know what types of calls you might get inbound as a part of this, and so we certainly still had to prepare for that. So we spent time thinking of, okay, what are kind of trigger words? I'm having heart trouble, difficulty breathing. Things that, your 911 disclaimer probably is there for to redirect or escalate to. And how do we monitor, calls that are coming in for that? And I think this was given particular sensitivity for after hours coverage, right? When no one's there to answer the phone, when should it escalate to, the on-call line, those sorts of things for patients? Because that's, starting to push into clinical decision-making territory a little bit around that almost. And so I think that's where, we spent the most time of how do we really refine those edge cases a little bit, knowing that the vast majority are going to be much more clean cuts. And that'll be very few that, trickle through the other route. And we just have to make sure that we're prepared to support them at those given times. So that's a little bit how we've thought about it of, really focusing the use cases on where there's the most value, how can we augment our teams to Matt's point, but also, preparing for those edge cases because they're certain to happen. And I think even more so now too, I know everyone's very concerned about cybersecurity and incidents like that, identity spoofing, somebody's pretending to be somebody else that, could be occurring too. And how do we ensure that someone doesn't, provide enough data points to access clinical information over the phone? That's something we really wanted to be, rigid about and make sure we had the proper protocols and points of validation in place.
Yeah. Or kind of on a related topic, you raised something that I thought was kind of interesting in our prior call, which is, right now, everyone over there is kind of watching what's going on. There's a lot of attention on it, but, once the project moves out of the spotlight, there's risk that the attention fades and there's not the same level of kind of scrutiny and oversight. And so how are you guys kind of thinking about that and ongoing kind of quality management in general.
Yeah, exactly. And it goes to scaling. What we were talking about in this conversation is you can't just turn it on and then just walk away. We just launched these outbound call agents in February, and it's hot right now. So everybody's really curious. We're in the dashboard every day. We're looking at the transcripts. I can't wait to see what kind of conversations patients are having with the agent. I'm always so surprised and so interested. So we're looking daily at every transcript, and we were very cautious. We want to make sure nothing's going off the rails and that the conversations are going as we'd expect. But exactly just as you said, Bobby, that attention will fade. And as we add additional use cases, we won't be able to scale along with it where we're watching every transcript and every conversation. So the important thing there is to make sure that you have the right insights in a dashboard. That was another lesson learned for me, is making sure that you build in your reporting requirements, because you don't want to have to audit every transcript, but you do want to have the confidence that these conversations are happening the way that you would expect. So we worked very closely to make sure that we were building machine learning to analyze the machine learning. So we wanted consumer sentiment metrics. Are patients sounding frustrated? Are they cursing? Are they yelling? Right? So we have a consumer sentiment score for every conversation. Patient experience scores. Did the right outcome happen after the call? Did they get to the right place? Did they have to repeat themselves? And then also call duration can be a great indication that these calls are happening as they should. Calls shouldn't be long. If you see a call that's over 3 minutes, maybe even over 2 minutes, that's something happening there, right? In our case, when we see that, it's like a loop happening between the AI agent and someone's voicemail, kind of going back and forth, and no one's ending the call. But that's an indication. So if you have the right dashboards, then I can just go in and I can click on the calls that are not meeting our thresholds for consumer experience, sentiment, and duration, and then I can see what went wrong there. So you have to be able to take the time to build the right dashboard so that you can scale along with it, right? It's a point of great interest right now, but next month we'll be on to the next use case. So you want to make sure you have those insights in there.
And has there been any observations that you've had that have been surprising? Things you didn't expect to see as you're kind of digging through these transcripts and some of these early metrics?
Yeah, I did not expect patients to really have communication with this virtual assistant. I didn't think they were going to ask questions. I thought they would just hang up, maybe confirm their appointment, right? So our agents are calling patients saying, hey, your colonoscopy is 1 week from today, reminding them about a few things they should do, and then asking if they have any more questions. 41% of patients are confirming that they'll show up to their appointment, which I thought it would be 7%. Our benchmark was 7%. So many more patients are confirming that they'll be there, answering, confirming their identity, and saying that they'll show up, which is reducing operational burden by 41%, right? Those are all calls our operational teams don't have to make. But the part that's really surprising is how many patients are actually asking questions to the agent. And we've learned that they're asking questions maybe about things they'd be uncomfortable asking to somebody live, right? Colonoscopy is very personal, maybe kind of embarrassing, and they seem to be more comfortable asking questions about some of those sensitive topics to a robot than to a live person. So the questions themselves have been really interesting. I mentioned we had all those FAQs that we used to train the model. Well, those were anecdotal FAQs that we just asked our team, what do you hear often? And now I can see what the real frequently asked questions are, and we can build out our knowledge base of the real frequently asked questions, because now I have data on what patients are actually asking. Things like, do I have to take out my dentures? We never had that in our FAQs, but it's something patients want to know. So just really being able to understand those insights, and then you're gaining more knowledge about the mindset of your consumer, and that's extremely valuable.
Yeah, that's super, super interesting. And you touched a little bit on the next question I wanted to ask. So, feel free to add anything you think is relevant, which is, you'd indicated that some of the early results that you were seeing have kind of also blown past your expectations.
Yeah.
Can you talk a little bit about how you set this up? Because I think you did some kind of interesting design on the testing front, and then kind of what the early results have been.
Yeah, thank you so much, Bobby. It starts with that business need. And so we wanted to increase completion percentages. And so we're holding out a no-mail control group. Half of the patients who have an upcoming colonoscopy aren't getting calls from the agent. And so we want to make sure that we're comparing patients who had this outbound phone call from a virtual assistant. What is their completion percentage versus patients in our control group who had the business as usual experience? So we're trying to see if there's a lift. So for 3 months, we're going to be running this test. Like I said, we started end of February, and we're going to keep running it through the spring. And then we'll see, did it actually deliver on our ultimate goal, which is increasing completion percentage and thereby reducing cancellation and no-show rate. And that's how we'll calculate the ROI. So balance the control groups by site, by the existing completion percentage for our endo suites to make sure that things were really fair, and we're really taking a measured approach. It's not the AI headline flashy, here's a cool solution. We want to make sure that it's delivering business value. So that's cool.
Got it. And you had said that early results are showing materially higher completion rates than kind of the status quo.
Yeah, and more engagement than I ever expected, and less time for our operational teams to have to spend on the phone making that outreach. So those 3 points where early results are showing great progress on each of them. So it's really exciting, and it's fueling us enough that we're starting our next use cases now, which is great.
Man, I want to stay on the topic of kind of ROI and value measurement. So you guys have been live for a while now. I'm curious how you've been thinking about ROI and how you've approached measuring it. What's, maybe what's worked or what's been even challenging potentially.
So we've been really digging into this lately, trying to figure out, what have we learned from this implementation and help us guide where in other aspects of our organization would this make sense. I referenced being ready to do this work earlier. We had expanded our templated capacity substantially in the lead up to the deployment. So one of the things that we've been able to do, right, through accurate call routing and training the agent up to take on enhanced scheduling skills was actually increase the number of appointments scheduled on a monthly basis by our human agents. They've become much more efficient. It's about 20% more efficient. I think that's a combination of we've given them more appointments that are schedulable, like, take the AI out of it. The work we did to lead up allowed more appointments to be scheduled by the central department. But we've also taken off non-scheduling related calls. So basically they're only doing scheduling. This is great, but I think both of those things go into understanding why. Amy, our agent, is helping and teasing out sort of some of the non-value added work our scheduling agents were doing prior to that implementation, but we've also done a lot of legwork to allow. This is the issue in really any healthcare, right? Like, we don't have some nice, neat control environment to know which intervention is actually driving the value here, but we know they're both supportive and complementary of each other. We've been taking a really hard line on what the value is. Like, what actually is the time savings of the calls that are autonomously handled? And in that instance, we're getting about 12 FTE worth of work out of the agent right now. We anticipate that number going up to 20 here soon, but right now it's about 12 FTE we're getting out of the agents.
I want to do a quick lightning round with everyone, then we'll jump into the actual audience Q&A. And so maybe DJ, I'll start with you here. What's one thing you wish you would have known at the start of your voice AI journey?
Yeah, I might offer two if that's okay.
Please.
The first that I would really stress is that, we're living in kind of a non-linear world now. We had very much thought about this as kind of a linear deployment of every week or 2 weeks, we'd add a new feature or a new function to it, see how it does, refine, adapt, layer in the next one. What we found is that we're able to move, exponentially more quickly to deploy features throughout our pilot period than we thought we were going to be able to at the front end, and really listening to our vendor partners of leaning to their expertise of the best way to deploy it, and kind of removing ourselves to Matt's earlier point from maybe the IT water flow methodology of the past a little bit for us. The second thing I'd offer as well is, these AI agents are, infinitely patient and compassionate with patients as well. To Orla's point of, these are delicate things that they're talking about with the patients, right? The patient wants to feel validated, feel heard as a part of it. And AI has infinite ability to be able to do that or have specific expertise for that patient needs in that moment. So I think those are two things that we've learned throughout this that have been points of validation for us that we really need to lean into this as a path forward.
Orla, how about you?
Yeah. For me, I wish that I had realized that there is no standard out-of-the-box dashboard or reporting structure, right? Define your reporting requirements up front, because that's going to inform how you build everything that follows. I think I sort of expected, like, okay, great. What's everybody else doing? Show me the dashboard that everybody typically uses for something like this, and it doesn't exist, right? So just define those metrics that you want, those indicators of things like outcomes and patient satisfaction, whatever your objective is for your particular use case, define those requirements and work to build that dashboard upfront, because you may hit limitations and things that you're not able to capture, and that may make you feel differently about how you're engaging with your patients in different communications. So upfront dashboard, there's no standard out of the box dashboard that's going to meet all of your needs. Define those reporting requirements early, because it will shape how you build the model.
Makes sense. Matt, how about you?
Yeah, I mean, I think I've hit on a couple. I think I mean, maybe some of it was, I don't think it was planned, but being ready to implement has certainly made the implementation substantially easier. And I think um, if you think if you're really struggling in your call center and you're going to layer in AI and it's going to make it better, you're probably wrong unless you've got a really detailed understanding of how clean your processes are today. I think that's really a key. And then I think the other thing is you like we I think we still are overestimating patient resistance to this. We did a similar sentiment analysis that Orla referenced doing recently. And I mean, don't get me wrong, I was just dealing with one like 5 minutes before we got on the webinar, a patient complaint, that seemed to be about the agent. And when we did the investigation, the agent did nothing wrong. The patient just refused to engage. So that's not going to be a solvable problem. And when we do the sentiment analysis on our engaged phone calls, it's 99% positive. So don't react and don't manage to the 1% loud squeaky wheels posting on Nextdoor. This is the way of the future. I mean, somehow airlines have convinced us that talking to humans is horrible. We need to figure out how to make that the same with related to scheduling and healthcare.
Yeah, I agree with that. I thought patients were going to be yelling representative, but they're not. They're not. Yeah.
But listen, we had to teach ours all of the curse words.
Yeah, exactly.
In fact, the fastest way to a representative is call my number and drop an F-bomb.
You might not want to make that public.
Yeah, it's true. Yeah.
Awesome. Well, great. We've got about 15 minutes left, and we've got some good Q&A in here. So I want to dive into that. Let's see. The first question, I think this is an interesting one. And Matt, I think I'm going to come to you on this, which is, how do you look at future hiring of call center reps? Does it change who you hire, their experience, types, et cetera? Curious if you have any learnings there.
Yeah, so Orla's got this one nailed too. This is all about understanding your data. Because until you've completely replaced the entire functionality with the technology, your performance is still going to be somewhat related to having humans answering the phone. Now, you can't go onto the website and punch your numbers into the Erlang model and figure out how many FTEs you need for a certain service level anymore, because your agents are doing a large amount of that work. So you have to have an even better understanding of your metrics. Call center people turnover. I think you have got to understand your demand, and I think we're not doing it in the same way we used to, right? So it used to just be everything was a call, but now we're trying to deflect calls all over the place. You can make everything you can schedule with the AI agent, you can schedule through your phone. You can schedule online directly. So we're investing in all of these strategies to connect our patients to the scheduling templates in new and unique ways. And they all go into how much telephonic demand do we have, how much is going to get through that technology and still require a human. You've got to recalibrate your staffing to that new normal, and that new normal is not static. It is dynamic. It is different tomorrow than it is today.
DJ or Orla, I know you guys are both maybe a little earlier in your journey. Anything you're seeing so far, or still kind of TBD?
One hypothesis that we have right now of kind of where we'll be taking this is that it'll free up our contact center staff to do less of those transactional items on a day-to-day basis and focus on some of the higher value add activity. And what that can mean over time for them as well is more investment in their training, our ability to retain them over time and upskilling them to do other things that they may want to do as a practice, and really build a stronger career ladder for them where we retain some of that institutional knowledge. Their handling the exceptions, the highest use case things, and how do we start doing some of the proactive pieces that when the lines open on Monday morning at 8 a.m. or between 11 and 2 p.m. to Matt's point that you're drinking from the fire hose, how do we start to balance that across the day a little bit? So we're really thinking about it of, how are we deploying people on, higher value add activity and use it as a way to retain high performers as well and upskill them over time.
I would echo what DJ said. In our case with this colonoscopy use case, we're talking about operational team members, not even call center agents, right? So we want to alleviate some of that burden of having to pick up the phone and chase patients and really make sure that they'll show up, please, so that they can focus on other things. We're trying to take that burden off of them so that they can go back to doing what they love to do, and that's really delivering patient care.
Yeah, makes sense. Cool. Next question, and this is probably for Matt or DJ. It's a little more focused on inbound call workflows. This is more of a design question. Like, how have you designed it relative to your IVR? Is it taking all of your inbound calls and then routing appropriately? Does it sit behind an IVR? Like, is there anything that you've learned or can share about how you've actually structured it?
For us, the very first thing it did was completely replace the IVR. So don't press 1 to talk to your agent. Like, hey, I'm your digital host. How can I help you today?
Yep, and I think in a similar spirit as well. That's where we expect that we will be. Is that will be the agent will be the landing place when you dial in today. To get our pilot set up a little bit quickly, we did decide to elect and have it be hit 2 on the IVR goes to the agent at that point in time. But definitely when we deploy this at scale, it'll be when the patient hits the line first, it'll go to the agent, it'll route the call appropriately, and I think that's really what we see as best in class.
Got it. Let's see, scrolling through some of these. This is an interesting one. Obviously, understandably, health systems provider organizations tend to be very conservative around approvals for languages used and things like that. I'm curious if you have any learnings from how you got approvals or how you worked with your internal legal teams or privacy teams or anything along those lines to get comfort
Probably do a
around
whole
this.
webinar on AI governance.
We have actually.
Yeah, I mean, so that's really what you're talking about here. I mean, most mature systems have stood something up about that today. I think we've evaluated like 112 point solutions. We've deployed 60 of them, 30 being native to the EHR and 15 of them through Palantir and then 15 other sort of points. But there's a very rigorous process that people smarter than me have designed, and people smarter than me understand what to evaluate. I'm just the operator.
Yeah, I'd say same. AI governance committee is super important, but having a great partnership with legal and compliance up front is critical. And in our case, because we were using an existing partner who has actually done outbound communications for us through SMS in the past, making sure that we're really identifying the patient in that conversation before we proceed with even sharing anything about an upcoming appointment is critical. So it goes beyond just use of AI. You have to make sure that you're not disclosing PHI or any personal identifiers on that call. The agent needs to make sure when they're doing outbound calls that they're talking to the intended person. So making sure that you have those identifiers and safeguards in place before the agent just starts talking and disclosing information is important too.
Next question. We haven't, and I'll ask this broadly, and any one of you can feel free to jump in. How is it, I'll say, what's been the experience integrating this with other systems? Be it your EHR, your telephony system, anything else you needed to hook into here? I'm just curious how much of a lift that's been and any learnings in terms of going through that process.
Yeah, I'm happy to kick us off here and then would welcome comments from others. But this is something that we kind of thought a little bit at the front end with our RFI process of making sure there's compatibility with the systems in place. We've spent a lot of time and energy really doing integration over time to be all in one instance of the same EHR over multiple states. One call center platform, et cetera. And how do we really lean into that and make sure things are compatible? And what it actually raised was a good question for us. It wasn't so much of, how do we, fit it into the existing environment? It started to turn the conversation to be, what investments do we need to make in our environment today to prepare us for the future? So yes, we might be able to deliver on, using AI for contact centers today the way we've contemplated it. But 2, 3, 5 years from now, will that the same solutions that we have today be the solutions that we need to support the AI infrastructure or the kind of the ecosystems that we'll have in place at that point in time? And that so it's opened up a lot of dialogue on that, I would say, of how do we be more thoughtful about that.
Yeah, I'd add to what DJ's saying, but the EMR integration is key. That we wouldn't be where we were today if we didn't already have the EMR integration in place. But beyond that, you want to make sure that you have the capabilities to streamline your tech stack. So I want the data from all of these interactions, from our AI assisted call routing they're about to launch next month, and this outbound calling that we've launched already, to go into central, at least a data warehouse, right? You want to make sure that you have those CDP capabilities in place, because you want to know if patients are calling multiple times. You want to identify where they're calling. And when you're doing outbound, you want to capture those interactions too. So you just want to think more holistically about the patient experience, because you can capture incredible amounts of data. You can see which patients are the most needy, which ones have the most questions, which will call more frequently, which patients are more likely to schedule online versus by phone. So beyond just the integration into Epic, you want to make sure that you're extracting all of that data and ingesting it into some sort of central CDP structure.
Got it. We had a question around how folks' experience so far has affected their perspective on using this type of technology for more clinical triage or just clinical calls in general. And so I'm curious if, based on early experiences, this has made that seem more likely, less likely to you, any kind of perspective on more truly clinical calls.
Yeah, we're really close to announcing something really exciting about that. This space is moving very, very quickly, and there are actually quite a few more people than I thought were out there already doing live clinical triage. Usually nurse triage 24/7 with an agent. I think there's human in the loop that you need to be very considerate of in that type of model, which has an enhanced expense to it, but it may not be with, it's unlikely to be with the same vendor. And I think that's probably one of the things that we're going to need to start considering, because I can't have 15 different AI voice agents that we partner with. So I think the consideration of the future is both meeting our business needs and partnering with a company that can adapt and deliver on those.
Yeah, I'd agree as well. I think we're closer than people perceive we may actually be on this. We're not as far away. And I think if we were to have this webinar again 1 year from today, we'd all be talking about how there's some great pilots and proof points already out there. So I don't think we're as far away from that as people believe. We've kind of are tiptoeing into it a little bit with some of the, the red flag words I mentioned earlier. Colonoscopy prep's also going to be probably an early use case for some simple questions and things along those lines before doing something more complex. But the technology is definitely emerging at a scale and competency that we're not too far away at this point from having solutions available in the marketplace.
Yeah. And this kind of connects to the next Q&A question. So it'll overlap a little bit, but curious how you'd extend it, which is, where do you see this technology going over the next few years, especially given your early experience? Are there certain things you now expect or things you particularly want to see? I'm curious kind of how these early experiences have shaped your thinking on that.
Yeah, I think there's going to be kind of two paths here. One is, particularly for contact centers here, much more, I would say, of like a CRM-like model in the future that many other, industries have adopted. And I think healthcare has been a little bit behind on. So I definitely see, my question is, how are some of these solutions going to bridge the gap to becoming a CRM in the future and what that might look like? I think the other path is more clinical decision support tools and developing kind of robust things around that beyond just contact centers, but other types of AI to support that as well in the future. So it'll be interesting from my perspective to see which path some take, as those seem the kind of the two most likely options in my mind.
I think there will be major consolidation happening. There's so many players, and I think we're sure to see a lot of consolidation in the industry.
I think
Any thoughts? Yeah, okay, sorry, go ahead.
you're going to increasingly struggle to tell the difference between a human and the tech. I think right now it's still fairly obvious due to the latency issue and just some of the robotic nature of some of the voices. And I really do think that's going to make a big difference. It's just more comfortable when it is a more conversational feel. And that's when you're going to start seeing a lot of success in outreach as it relates to population health, chronic disease management program enrollment, or even program management that I think will really help from a value-based care perspective.
Mhm. And, and another kind of related question, how have these initial experiences shaped your perspective on, I'll call it technology stack structure, right? Meaning, when are you thinking about, do I rely on my EHR to provide this functionality? Am I looking for, called a quote unquote voice related platform? Like, how has this shaped, as you think about kind of the major building blocks of the technology that you have in house? How has this shaped your thinking there?
I mean, from our perspective, as a relatively new system, we've only really been in systems for 6, 7 years now, and we've grown substantially through acquisition. We will more, I think, at the front end, prioritize getting folks on the tech stack that allows the tech to scale. So, for example, we have a business unit right now that really find a lot of value in, even just having the digital host answer the calls and do patient identification. But they're on a different telephony system. And so we can't do anything until that happens first. I'm not saying it would have made a difference in our decision to acquire them, but we absolutely will be considering that as sort of table stakes and moving forward.
Mhm.
And I think the other thing that could emerge a little bit too is you have to be really diligent about what is going to be, maybe a more of a value solution, right? That, where you're balancing cost and service level as a part of it versus something you really do need a kind of best in class or leading capability for that you're willing to pay a premium for. And I think sometimes that gets mixed a little bit in some of these conversations and trying to distinguish it. But I think having a lens to that will help, create some decisioning criteria around it for any organization.
Well, we're just about at the end here, so I'll open it up. Orla, DJ, Matt, anything else that we haven't touched on, covered, that you want to leave the audience with?
Well, I want to thank you so much for having me. This was a great conversation, a great dialogue. And I guess if I were to leave you with a piece of advice is just make sure you talk to the clients of these partners, right? Get some case studies and really talk to users who are on the front lines and have been using the technology, because everything sounds great in a deck. But when you actually talk to different health systems and you hear how it's been working for them, you'll learn a lot. And I think that the healthcare industry is great at that, right? Like, we're very happy to share who we're working with on what projects with each other, because we're all sharing a common goal to help care for the community. So definitely talk to your peers and ask any vendor you're talking to for client references and have those conversations.
Yeah. Likewise, thanks everyone for letting us participate here today. And I think one thing that I would leave folks with as well is there's a lot of inbound solutions people are telling you it's important to do this. Listen to your constituents. And one of the things that we found when we did that is actually our physicians were demanding this, right? They saw the opportunity here, and that really helped push through a lot of the organizational inertia, if you will, to get it across the finish line. So find great champions and listen to your constituents on this. They'll likely help propel you forward, not hold you back in many times.
Yeah, and I'll just summarize and say, start doing the work. You've never seen anything like this before if you're not actively doing it, and you won't learn how to make it better until you put it in. So we're classic in healthcare to let perfection be the enemy of progress. You just need to move, and that you guarantee you in the next age and answering your calls. You might as well start now.
Well, great. Well, Orla, DJ, Matt, thank you. This was fantastic. Thank you everyone for joining us. We will be sharing the recording around, so if you missed a piece of this, you'll be able to catch up there. And yeah, hope everyone has a great Monday and see you again soon.
Thank you so much.
Thanks, folks.
Appreciate it.
Everyone.
Thank you. Bye.